and deaths as a therapy for DUB and functional ovarian cyst, prevention of PID, ectopic pregnancy, fibrocystic and benign breast disease and bone loss, treatment of acne, hirsutism and perimenopause. So much of advantages are there in use for her family planning. So these are the factors that decide an individual's overall health. That has to be pregnant within 2 to 3 years, or she wants a long term. On this, we can decide the method of choice, and side effects and contraindications has to be or factors that decides the method of choice. Frequency of sexual activity, number of sexual partners. This holds good for Western countries. அப்படின்னு நம்ம இவ்வளவு நாள் நினைச்சோம், இப்ப அப்படி இல்லை. உள்ளுக்குள்ள போய் பார்த்தா நிறைய விஷயங்கள், both in rural as well as urban, not urban alone, rural also most things are happening which is very hot shaking, and so we have to take these also into consideration when prescribing advice for a women. Desire to have children in the future, family history of certain disease. Women use contraception not only as a way to prevent unintended pregnancies, but also to improve their health and health of their families. That's very to be underlined. It is not only the women's health alone. In turn, it reflects upon the society. So increased access to contraception is directly linked to decline in maternal and infant mortality. So methods of contraception, these are all, I am not going into detail. So only on updates, recent updates, I am going to concentrate. So natural, just for a completion sake, I have included this slide. Natural methods, you all know, abstinence during the fertile period, withdrawal method or coitus interruptus, breastfeeding, lactational amenorrhea method. And barrier contraceptives, condoms in males and females, spermicidal agents, hormones altering the cervical mucus and preventing the entry of sperms, and intrauterine contraceptive devices, as we all know, suppression of ovulation, nothing but OCPs, interceptive agents, post-coital contraception, which is very prevalently used. Adolescents, they don't know anything. They know everything more. So that is a situation now which we have to accept, and we have to guide our younger generation in a right path. And immunological methods, suppression of spermatogenesis in males, surgical sterilization. So இது எந்த அளவுக்கு அப்படின்னா, ஒரு ஸ்கூல்ல நமக்கு இண்டிவிஜுவலா இது கொடுத்துருவாங்க. ஸ்கூல்ல ஸ்டூடெண்ட்ஸ் டெய்லி அந்த புக்கு முட்டையை சுமக்க வேண்டான்ட்டு they give individual cupboards. இப்போ இந்த வருஷம் கொடுக்கல அந்த ஸ்கூல்ல. ஏமா கொடுக்கல, இவ்வளவு முட்டையை சுமக்க விடுறீங்க அப்படின்னு கேட்டா, ma'am, it landed up with many problems. So they found condoms inside those. See how in a school this thing is happening. So really it is very, very pathetic. அதான் சொல்றேன், நமக்கு நம்ம நினைக்காத அளவுக்கு they know everything about family planning, and one way it is good, but one way we have to teach moral values. So that is high time to teach moral values to methods is measured by the number of pregnancies calculative index. So this very effective method is 0.2 to 0.9 pregnancies per 100 women. Effective is 1 to 9 pregnancies. Moderately effective is 10 to 19, and less effective is 20 or more pregnancies. So based on this, we can choose the contraceptive method. So how this is being calculated by Pearl index, this every OG person know. And number of contraceptive failures per 100 women, years of exposure, and uses as the denominator the total months or cycles from the initiation of the product till the discontinuation. That's all. அதுக்கப்புறம் longer. எடுக்கிறதுல இருந்து ஆரம்பிச்சு முடிக்கிறது வரைக்கும் how many failure rates is there. So that decides Pearl index. So based on this, on ideal contraceptive, how it should be. It should be safe and effective first, and easily available. It should be affordable for countries like India, developing countries. Cost is very much important in deciding the contraceptive method. Side effects, reversible, very important. It should be reversible because many females are worried about it, and acceptable by the individual. So by providing access to a diverse array of contraceptive methods, fostering informed decision making, and upholding human rights, we can contribute to healthier societies, gender equality, and improved quality of life worldwide. So this is the thing I sent to Mohil, and based on this slide only I prepared my talk. So to prepare to go towards a healthier society by providing informations on update of contraception, so that we can decrease the maternal as well as infant mortality, a healthy society is being used. So hormonal contraception combined birth control pills contain this is physiology. So preventing ovulation, thickening of the cervical mucus, and thinning of the endometrium. So these are the methods, mechanism, but thickening mucus is the most important mechanism of action of progestin-only pills. So oral contraceptive pills available as monophasic, biphasic, triphasic, four-phasic, even tried till monophasic stands as the gold standard method for follow-up of the individuals. Then progestin-only pills. Monophasic pills, these are the examples. Most commonly ethinyl estradiol or norethindrone. So many, I found humpty number of this trade names. No, really, இது எப்படி நான் பொசிஷன்ஸ் நினைச்சு கொஞ்சம் பாவப்பட்டேன். இது எப்படிதான் இவ்வளத்தையும் மனப்பாடம் பண்ணி எப்படி எழுத போறாங்க ட்ரீட்மெண்ட்ல அப்படின்னு சொல்லி. அவ்வளோ நம்பர் ஆஃப் ட்ரக்ஸ் ஆர் அவைலபிள் for as oral contraceptives, different trade names. So ethinyl estradiol and norgestimate, drospirenone and ethinyl estradiol, drospirenone and ethinyl estradiol, and levomefolate. But throughout the month or 21 days, only same dose of same drugs are being used. So biphasic pill, 500 microgram of norethindrone plus 35 microgram of ethinyl estradiol for 10 days, followed by 1000 microgram norethindrone plus 35 microgram ethinyl estradiol for 11 days. So different combinations are used in the same month. So this is just an example I have given. Many are available. And triphasic pill is called, classical example is trinovum. The drugs that is used for triphasic pill: norethisterone, ethinyl estradiol, norethisterone 0.5, different doses, and norethisterone 1 milligram. So the different doses of drugs, same drug. Recently introduced estradiol valerate and Dienogest combined of heavy menstrual bleeding. So it adverse effect of using contraceptive pills. So this four-phasic pills eliminate that. Breakthrough bleeding is reduced and fewer spotting days, so reduction in the mean blood loss. It also increases the HDL level, which is good for the female, and stability in carbohydrate metabolism, and significant improvement in hemoglobin, hematocrit, and ferritin levels. So because of less blood loss and breakthrough bleeding is being reduced, there is good hemoglobin levels for the patient. So progestin-only pill is norgestrone and noride must be taken within 3 hours of the same time each day, and desogestrol pill such as Cerazette, so that is a trade name, must be taken within 12 hours of the same time each day. And progestin in combination pills, how it is used. So different types of progestins is there. One progestin will have acne as a side effect. One progestin is used as a treatment for acne. So that is the progestins act as androgens. So they play a role in acne and excess hair, effective than another at reducing acne, whether the complications is there or not. And so of progesterone, which is used in combination pills, desogestrol, it reduces excess hair growth and acne. I said no. So this particular progesterone is reducing the excess hair growth in the combination pill. So combination control pill comes in so many names, Apri, Azurate, Kariva. So it causes symptoms associated with hormonal birth control. It's a common symptom for everything. I will come to that side effects later. And drospirenone is another drug. It has diuretic properties. So the bloating irukad. Commonest side effect the females will complain after OCP is உடம்பெல்லாம் ஊதுன மாதிரி வந்து நம்ம கம்ப்ளைண்ட் பண்றதா சொல்லுவாங்க. This bloating is mainly due to this progesterone which is present in the combined pill. So this particular drospirenone, it eliminates that by having diuretic properties. So this can be prescribed. It has been done on this, and it is shown that it helps to treat premenstrual dysphoric disorder, PMDD, very difficult migraine போவாங்க ஒரு சிலர். So அந்த மாதிரி இதுக்கு வந்து this drospirenone is very effective, and these are the drugs combinations available with drospirenone. And levonorgestrol we all very well know, and this is treatment always holds good. And Aviana, Lessina, Livora, Lutera, these are some of the drugs trade names available with levonorgestrol. Testosterone and common side, naturally it should be the hair growth and acne will be there because of testosterone content. These are some of the names related with norethindrone. and nor gestimate available. And next, this is birth control pills. This is seasonal or continuous. So for a particular season or throughout, and the mari rendu combination irukku. So this packet contains 12 weeks of combined hormonal birth control. 12 weeks together you have to take. And packets also contain 1 week of placebo or low dose ethinyl estradiol. Some people prefer periods வராது, ரொம்ப ஹாப்பி இல்ல, அதனால நிறைய பேர் வந்து they prefer this drug. So what is third, can do so safely up to 12 months வரைக்கும் இந்த drug வந்து நம்ம யூஸ் பண்ணிக்கலாம். So it is good to use. And as with other birth control, இதுக்கும் அதே side effects கண்டிப்பா இருக்கும், இல்லாம இருக்காது. And taken continuously for 84. Continuous is 0.09 milligram levonorgestrel plus 20 microgram of ethinyl estradiol for 365 days hormone withdrawal and diminished blood breakthrough bleeding for 8 to 9 months. Monophasic versus triphasic. As I said, monophasic is always taken, even though triphasic is having some theoretical advantages. Each packet of triphasic birth control contain the dosage of norgestimate increases each week. Hormones throughout the message. So whatever we have naturally, this triphasic pill is going to, it controls in aiming the reducing the side effects by mimicking the natural fluctuation of hormones throughout the menstrual cycle. However, limited research on whether triphasic pills cause fewer side effects than monophasic pills. So according to an older 2011 study, they do not appear to be more effective than standard monophasic birth control pills. And monophasic pills provide the same amounts of days followed by one. This is a comparison between monophasic still further for knowing about its less that is side effects and its effectiveness. So progesterone only birth control pills, anyone who many cannot tolerate estrogen. Estrogen is a condition நம்ம கொடுக்க முடியாது, whether mainly heart disease. Heart disease இருந்துச்சுன்னா கண்டிப்பா நம்ம prescribe பண்ண முடியாது. So in such case, we can go with progesterone only pills. Micronor is an example which contains norethindrone, and Slind which contains drospirenone. So these are the two brand name examples. Micro may suit people who experience side effects on combination birth control pills. And adalime or minimal amount of norethindrone will be there to have efficacy. How to choose? So far we have known about what are all the oral contraceptive combined pills available only, extended cycle pills, all these. Now we are coming to the point how to choose a birth control pill. So certain factors has to be considered by picking a birth control pill. What are they? Estrogen is not safe. As I said, it may increase the risk of blood clots, thromboembolism. So very, very worst side effect, but it is least reported. அதனால தான் இன்னுமே combined oral pills use பண்ணிட்டு தான் இருக்காங்க. Additionally, some form of progesterone is high clots and worsen the acne. So in aesthetic sense, கண்டிப்பா progesterone கொடுத்தா நிறைய அந்த male characters அந்த மாதிரி வரும். அதனால nobody likes that. So these are the common side effects with any pill: headache, depression, irritability, lethargy. This happens. It is very, very so contain, and in trade form it is levonorgestrel, good old standard we use from early days. It is available as Plan B in the trade name, and combined oral contraceptives can also be used. So Plan B is the most popular control method that has to be, particularly in a developing country like us, India. And cancers and COCs, contraceptive pills. Remember, told to the patient, protection persists for 20 years. As I say, colon and rectal carcinomas, it is protective. 37% case OCPs this way or that way. So it should be guarded. In CA breast patients, we should not prescribe. And counseling has to be done. So these are all things regarding the OC pills. And what are all the counseling thing you have to give in பொண்ணு நீங்க சொன்னீங்கன்னா எத்தனை பேஷண்ட் எத்தனை கேள்வி கேட்கிறாங்க அவங்கள ஒரு 10 தடவை திருப்பி கேட்பாங்க இந்த மாத்திரை எத்தனை தடவை போடணும். So we will get fed up. So that is public, நம்ம வேலை பார்க்குற பப்ளிக். ஸோ அப்படி இருக்கும்போது this pill நம்ம எடுக்கிறத வந்து கண்டிப்பான முறையில் எப்படி எடுக்கணும் எது எடுக்கணும்ன்றத வந்து we have to suggest and advise the patients. Information on potential side effects has to be told. Non-contraceptive benefits of combined OC pills, so far I have enumerated, and discussing the risks and warning signs, including when to cease not that much. But if it is going to combine with condom, definitely the efficacy will reach 99%. So the dual protection has to be advised to the patients. And informations about emergency contraception in the event of she has to take the regimen. Or low estrogen content, இருந்துச்சுன்னா நம்ம இன்னும் add up பண்ணணும். 2 missed pills in the 3rd week or more than 2 pills in any time அப்படின்னா backup needed. அந்த மாதிரி பேஷண்ட்க்கு 7 days நீர்தான் எடுத்துட்டு அதுக்கப்புறம் she has to start up from the again first. So these are the advices we have to give to the patient regarding missed pills. So far we have oral contraceptive pills. Now coming injectables. So injectables are available. Compliance will be good except for the pain of injection. Progestin only injectable. Depo-Provera, Megestron. This is prescribed. எப்படி நம்ம சஹேலி டுடே இதெல்லாம் நமக்கு ரொம்ப தெரிஞ்ச விஷயங்கள். அது மாதிரி இந்த 2017ல Antara was prescribed. That is nothing but Depo-Provera, medroxyprogesterone acetate, and 150 milligram given IM every 3 months. So once in 3 months, the compliance will be very good. So that can be given. Net-N, that is norethistron enanthate, and noristerat, that is given IM every 2 months. These are injectables. Combined injectables given monthly. Adu pathina cyclophem, that is medroxyprogesterone acetate plus estradiol, Mesigna. So these are the combined injectables available. And transdermal delivery system. So those are injectables. Transdermal are available. So these are things I came to know because since I am out of TGO for more than from 2005 I am out. So these are all things which I found out new since I prepared for the talk. So contraceptive patches or Thevra, transdermal gel is available and transdermal spray is also available. So transdermal patch is for 28-day, 21-day regimen. 2 things are available. Good compliance because just no injections, no drugs, nothing. So we'll be very happy. Except that it should be aesthetic sense that is not that is accepted. So avoid first pass metabolism. Oral first pass metabolism kadiyadu. So direct absorbance. Progestin with low androgenicity is available. Patch is noticeable. These are things which cannot be avoided. Minor skin reaction may be there. High cost. So when compared with OC pills or other devices, transdermal patch is bit cost or Thevra. And what is that you say? Scent போட்டுக்கிற மாதிரி இதையும் ஒரு ஸ்ப்ரே பண்ணிட்டு போயிட்டே இருக்கலாம். So daily you can do that for 21 days. Anti-ovulatory mechanism. It prevents ovulation. No skin irritation here, and bleeding pattern is maintained. So this is somewhat good, but we have to see the efficacy too. And transdermal spray is available. MDTS, meter dose transdermal system. Anti-ovulatory mechanism. Norethistron once daily. So bruising, these are all general complications of any OC pill. Subdermal implants are available. So levonorgestrone. Norplant R system is the only one that has been approved for distribution. 6 capsules, effective. So it is efficacy. And vaginal contraception by vaginal ring. This is application oriented. And 0.5 This name is also very familiar to the public. Nonoxynol 9, applied 15 minutes before intercourse. So it is a 3% contraceptive effectiveness. When compared with other vaginal gels, this is newly introduced and works by maintaining acidic pH and reduced IUDs. So far, oral contraceptives, combined contraceptive pill, and extended contraceptive pill, and vaginal spray, vaginal gel, and vaginal all these things, and subdermal implant. IUD impregnated progesterone receptor modulator. So it a higher atrophy. Failure rate is only 0.1 to 2.5%. So this needs expertise. So the patient cannot use by herself. Recent modifications of IUDs, Ombrel 250, Ombrel 3IT. And this is a frameless IUD. Frameless அப்படிங்கிறதுனால insertion will not cause much pain. So this is recently introduced. This also needs it is named as CU-fix or Gyne-fix. Pain, bleeding, expulsion. This is uncommon. So this holds good when compared with other IUDs. Can be used for 5 years. Mini version of LNG IUD, Fibroplant. that is also can be used. It releases 14 microgram of phenylestradiol daily, effective in treating endometrial hyperplasia also with minimal progestin side effects. And sterilization. So far the oral pills finished. Now coming to the sterilization methods. These are so new for me. Yesterday when a spring-like device plugged into fallopian tube. So it needs assistance. So Assure or mechanism, spring-like device into fallopian tube. Quinarin, it is a gel-like chemical compound introduced into the fallopian tube. The adeno procedure, it is a plastic implant inserted into a lesion in the fallopian tube. So tissue grows into it and causes inflammatory reaction, which will plug the tube. So that the transfer of ovum is being prevented. So these are all certain new introduced for sterilization procedures. And the only remedy against hunger is reasonable birth control. How? Because it controls population. So we are no more hunger, low socioeconomic group can be prevented. And male contraception coming to, so far we have gone with female contraception. Male contraception, new targets of hormonal approaches, mainly hormonal approaches, testosterone enanthate and testosterone and decanoate, weekly injections. So every week injections, testosterone injection per week. And SRMMCH, that is an entity where 7-alpha methyl 19-norgestrone implants are being kept for the men. Okay, so these are the male contraceptive and non-hormonal methods. Those are hormonal methods. Non-hormonal, if you take, target cetolizole indinopyridines with GnRH antagonist. So non-hormonal approach is good to prevent side effects of the steroids. And spermatid cetolizole interaction, there is a thing called adjudine available. It prevents the spermatid cetolizole interaction, which will intervene with your spermatogenesis. And HE6 epididymal duct specific protein receptor. So this guy will be targetedly deleted, which is HE6 epididymal duct specific protein receptor. So for OG PGs, if anybody here can take a note of it, which are recent introductions regarding non-hormonal contraception for men. And CRISP1. CRISP is nothing but cysteine-rich secretory proteins, preventing initiation of capacitation during sperm transit and maturation. And Casper channels, sperm causes the egg penetration. So they are calcium entry dependent. So what the name? Casper channels. So these are all the things in research going on. And CAMP, cyclic AMP, necessary for capacitation. So by controlling or avoiding that, we can prevent capacitation. Izumo, it is a sperm-specific membrane protein, IZUMO, sperm-specific membrane protein responsible for sperm-egg fusion. So that can be blocked to prevent the fusion of egg and sperm. And RISEC, this you must have heard of. It is nothing but reversible inhibition of sperm under guidance. So a clear gel injected into the vas, which will block it. So the sperm blocked. So that prevents fertilization. And IVD is intra-vas devices. So certain devices can be kept inside the vas deferens. Likewise, we saw in females within the fallopian tubes. And contraceptive vaccines now being invented. This confer long-term protection following a single course of immunization. See, it is very nice. One course of immunization provides long-term protection. I don't know whether the efficacy has been proved so far, but if it is so, it is a very good thing for contraception for males. Be free of overt pharmacological activity and the metabolic endocrine disturbances that often accompany other methods of birth control. And it doesn't require insertion of a device or an implant, remain effective without continuous monitoring, and be inexpensive to the manufacturer. See, single prick confiding a long-term protection that will hold good if it is going to be effective. And anti-sperm vaccines are in market, and functional antigens, structural antigens. Functional antigens, enzymes known to be required for sperm metabolism. Lactic dehydrogenase X, and involved in sperm-egg interactions and the process leading to fertilization, and the enzymes on the acrosin and hyaluronidase. These all we must have read in the physiology of male reproductive system. And structural antigens like the molecules expressed on the sperm cell membrane and which may be involved in gamete interaction and fusion. So these sorts of antigens can be given as anti-sperm vaccines. Anti-ovum vaccines likewise, antigen focused on the surface of zona pellucida that we very well know. Anatomy la moda embryology la padikira word zona pellucida maradhirukka mudiyadhu. The jelly like glycoprotein which coats the surrounding egg. So adukku against or antigen thatti vittona we can prevent the ovum product being produced. And no convincing data are available. See, everything kudutittu idheyum kuduthruvaanga. No convincing data are available to indicate that it can inhibit fertility without causing an inflammatory reaction in the ovary. So in the madri anti-ovum vaccines or inflammatory action illama idu act பண்ணவே முடியாது. So which might be indicative of a risk of acute ovarian disturbances. So reversible point gedamallama poirum. If she wants, if at all she wants to be pregnant again, that will be hampered. Adanaala these should be used in a guarded manner. And anti-conceptus vaccines, anti-sperm, anti-ovum, anti-conceptus. If at all being conceived, anti-conceptus vaccines are there. Placenta-specific antigens, structural antigens forming part of the brain, and pregnancy-specific beta-1 glycoprotein SP1. Anti-fertility effect was observed when female baboons and இது வந்து ஒரு ஸ்டடி பண்ணிருக்காங்க monkeysல. Actively immunized with human SP1, they show regression of conception. Another placental antigen, PP5, substantial reduction in the fertility was shown in animal models. And functional antigens like placental hormones have also been tried. So hormonal placental antigens are nothing but the HCG production or functions of HCGs can be inhibited immunologically. So these are immunological methods which can act as a part of contraception. Corpus luteum regress பண்ணி விட்டுறது. So support for the fetus will be relieved. So there will be no growth of the fetus. One type of anti-HCG vaccine developed by Population Council in New York and National Institute of Immunology in Delhi. Combinedly, they have produced based on the whole beta subunit of beta HCG. So that is under trial. Another type of anti-HCG vaccine developed with support from WHO task force on vaccines for fertility regulation is based on the portion of the beta. Again, the beta subunit of HCG. Carbox இன்னும் ஸ்பெசிஃபிக்கா உள்ள போறாங்க. The carboxy terminal peptide of the hormone that is being targeted to block the production of the conceptus. And these require multiple injections are required for such hormonal placental antigens use பண்ணீங்கன்னா not single injection is enough. Multiple injections are needed to achieve and maintain the levels of immunology and which is considered effective. So இது வந்து application wise it is cumbersome since repeated injections are needed. So that's about the latest things. So carry home message will be based on World Contraception Day, be careful, stay wise. That we have to say to the public. Okay, these are my references and thank you very much.
Ma'am, wonderful presentation, ma'am.
Thanks.
And I appreciate you. Actually, you have mentioned A to Z regarding the contraceptive and no more questions.
Sir, it is still the ocean, sir. I have covered very few things because so much information are available. Mukil ma'am to sonna Neelamni ma'am ta under இருக்கு ma'am அப்படினா எதுக்குடா அப்படினா ma'am ஒரு பெரிய ஓஷனை கொடுத்து அவார்டுக்கு பிரசன்ட் பண்ண சொல்லிட்டா. So it's so many things are available on contraception. Really it is அவ்வளோ நடக்குதா அப்படின்னு பாக்குறதுக்கு I was happy that I have come to know so much things about contraception by preparing for this.
Of course, you have started with contraception up to recent trend and research level you went inside.
Yes, sir.
So it's a great, amazing and topic, ma'am, and you have covered everything.
Thank you.
You have done a very good thing. Thank you so much, sir. And special thanks to Dr. Muir ma'am for giving this opportunity to chair this topic. Thank you so much, and thank you so much for all of you for patient listening. Thank you, ma'am. Any questions, please ask. I think the question does not arise. I hope so. Thank you.
Ma'am, sir.
Ectopic pregnancies are common in which kind of contraception? For ectopic pregnancies following contraception.
Combination pills. Anybody? Yes, please. அவங்க பேரு?
Ectopic pregnancy is common in Kadiyadu. The point of contraception is to prevent ectopic pregnancies. So they say OCPs to an extent are protective against ectopic pregnancies because it is supposed to decrease the risk of pelvic inflammatory disease, which is a risk factor for ectopic pregnancies. But when we use levonorgestrel releasing IUDs or progesterone implanted IUDs, the failure rate is very less. But if there is a failure rate, the chances of that pregnancy being ectopic is high because progesterone per se decreases the motility of the tube, or the fallopian tube.
So since the implantation inside the endometrium is prevented by the IUDs, the ectopic pregnancies, is it so, ma'am? It is not so.
Illa ma'am, the thing is progesterone, levonorgestrel releasing IUD, it locally releases progesterone. Progesterone is known to decrease the motility of the fallopian tube. So that is one of the mechanism of actions of progesterone. So it is LNG IUDs are 99.9% effective in preventing pregnancies. But that 1%, if they become pregnant, the risk of ectopic is
good. High. In that 1% risk of
0.1% the risk of ectopic is.
Yes. Thank you, ma'am. Thank you.
Ma'am, you said
Thank you, Dr. Muthuseli, for that very extensive talk, right?
Thank you, ma'am. Thank
Normally, when we take a class on contraception, I think we stop with 1 or 2 slides regarding the hormonal contraceptives. You have gone into such great depths of researching so much of I wonder, all of these, are they in the research stage or they have come to the market, ma'am, especially the male contraceptives?
It's in the research trial stage only, ma'am. I took it from journal.
Okay. Okay.
Yes.
And regarding this male contraception, ma'am, how much is it accepted by the society? I don't know, in the Indian society or...
Audience, please. Your comments are very well welcome.
To be very frank, we talk about empowerment of women and all of that, but as far as contraception goes in India, I think it is more of a family decision. And the mommy are taking the forefront. No, it's a fact. Our patients would rather have an abortion and then go for a permanent sterilization rather than take some form of contraception. They have a lot of myths about, I feel Indian population of the copper IUCD is the best.
Yes.
Because it is fairly easily available. It requires a little bit of training, and if put in properly, it gives a long-term reversible contraception. Whereas your injectables like Antara and all of that, there is a delay in return to fertility. So Antara sometimes it takes 3 months, 6 months, even 1 year before the patient can become fertile again. But the problem is when IUCD they will get an opinion from everybody, especially the neighbors. They will say, weight all these. So I do believe, and I feel contraception, we should start with properly given sex education at the level of the schools. It is not like they know everything, they don't. They understand a lot of things in a very weird way, which is not necessary. I think we need to start with giving students proper sex education in the school and then taking it from there. But even the most educated, they're not willing for contraception, maybe for religious reasons, maybe otherwise. So in spite of all the initiatives taken by the government to push it forward, females take the lead. And it is a sad thing because compared to female sterilization, which is basically an invasive procedure, you have to enter into the abdominal cavity. A vasectomy is a very simple procedure.
Yes.
But there are still misconceptions about the fact that the libido decreases and no male wants to do it, which is a real sad fact. Even with patients with heart disease, they want the female to get sterilized and the males don't take the lead. So I think our perception of a lot of things have to change.
Yes.
And we have moved forward in this field, though there are n number of methods available.
Yes, ma'am. So if at all at school, immediately after marriage also, we can start with counseling regarding male contact. Ma'am, is it the vaccine for males? Is it available here, ma'am?
No, ma'am.
No. If that comes, no, that will be a very great relief. But the efficacy is guarded, no?
Guarded, and no male will take it, ma'am. I don't know.
We can convince, no, because one shot it is going to prevent pregnancy means we should convince.
அப்படியும் the female version இருக்கான்னு தான் மேம் கேட்பாங்களே தவிர I don't know. I think it's possibly it's a patriotic society or whatever it is, but the involvement of the male in contraception leaves a lot to be desired as of now.
So, as you said, we have to educate from
education
schools.
The perception has to change.
Yes. Okay, ma'am. Okay. Thank you very much, ma'am. Thank you. Thank you, ma'am.
Ma'am, as of now, no vaccine. I mean, idella research stage la ma'am irukum. Nothing has come forward. If there is a permanent method, it will be a good thing. But usually, no vaccine is permanent per se. Very early to comment on any of this. And the other to think about is like COVID vaccine madri. I mean, it came out with a bang. But for long-term side effects are there for COVID vaccine. There's an increase in autoimmune disorder and all of that. So I think we should take it with a pinch of salt as of now.
Okay. Thank you very much, ma'am.
Thank you, ma'am. Now, we invite Dr. Etya ma'am to felicitate Dr. Muthuselvi ma'am with the shawl. Thank you, ma'am. Now, we invite Dr. Arivalagan sir to felicitate ma'am with the gift.
Okay.
Thank you, sir. We invite Dr. Muhil ma'am to felicitate Dr. Muthuselvi ma'am with the gift. We invite Dr. Nachal Annamalai ma'am to felicitate Dr. Etya ma'am. Thank you, ma'am. We invite Dr. Muhil ma'am to felicitate Dr. Arivalagan sir. Thank you, ma'am. We have Dr. D. Niraimadi, a distinguished professor of physiology, Indira Gandhi Medical Institute, Puducherry, will address the intriguing topic of hormone replacement therapy in menopause through a complex and relevant aspect of women's health. Please, we also invite Dr. K. Uma Maheshwari, Professor, Department of Physiology, ESIC Medical College and PGIMSR, and Dr. Nachal Annamalai ma'am, Senior Professor of Physiology, Trichy, to chair the session.
I'm honored to Professor Dr. Niraimadi ma'am from Indira Gandhi Medical College, Puducherry, She has completed her MBBS from Stanley Medical College and MD from Stanley Medical College. She has a teaching experience of 23 years and she has organized several CMEs and programs. She is staff advisor for the students and takes personal interest in counseling and motivating slow learners. I'll share my experience also along with this. I have seen her taking special classes for Tamil medium students at the evening hours from 4:30 to 6:30. It was out of her own interest. She has done all that. She has many research publications in national and international journals, and her areas of interest are respiratory and exercise physiology. Over to you, ma'am.
Thank you, Dr. Uma. Good afternoon, all. My topic is on menopause, the last stage of the women's reproductive session, and it has also been pushed to the last of the conference. Menopause is always a problem, I believe. So I know all of you are in the verge of hypoglycemia, so I will have a bird's eye view of your menopause and its complications. So we all know what is menopause. Yes, menopause is the cessation of the monthly cycles, and on the ovaries also complete their job and tend to atrophy and fail to produce the follicles, and so by end the hormonal levels, the protective hormones estrogen and progesterone. Last period ovulation is not happening. Menopausal transition, that is the changes before the complete or cessation of the monthly cycles. So the bleeding will be, the cycles will be irregular and ovulatory, and the complete cessation of the monthly cycles and the complications because of the withdrawal or the complete absence of the your reproductive sex hormones, that is the estrogen and progesterone. So with this introduction, we will go into my topic. Menopausal hormone replacement therapy, boon or bane. So by 2030, an estimated 47 million will be undergoing menopause each year, and this menopausal symptoms which were not noticed before because the life expectancy of the females or the general population itself was not very high. Before 50-60 the deaths were occurring, and now the life expectancy has been prolonged, and all of us are in Ilamai Thirumbudai mode. So everybody want to have a good life expectancy and the quality of life after menopause also. So now the menopausal hormone replacement therapy is gaining popularity and importance to improve the quality of life for the menopausal women. So all the distressing symptoms which affect the quality of life should be addressed first, and the prevention of the postmenopausal complications also should be taken into care. So how many menopauses are there? So if you see the spontaneous menopause, which is the normal physiological after 1 year of the last menstrual period, then usually it occurs between 45 to 55 years of age, average is 51 years. And the woman has entered the menopausal transition, that is, she has experienced a period of perimenopause with all its symptoms, and then the menopause happens. And the FSH and LH levels are elevated due to disinhibition because there is ovarian failure, that is ovarian not failure, the ovary stops working to produce the sex hormones, so the FSH and LH is elevated, and estradiol levels and progesterone levels remain circulating at very low levels. So these are the criteria for spontaneous menopause. And the next one is premature and early menopause. So entering menopause before 45 years is considered as early, and before age of 40 it is designated as premature, and also it is called as primary ovarian failure, and 75% it is idiopathic, and also it has many other reasons like autoimmune diseases, any hormonal dysfunction in primary ovarian failure. It is called as premature menopause. For a diagnosis of premature menopause or primary ovarian failure, it requires 2 occasions of amenorrhea for over 4 months, and it should be augmentation of the circulating gonadotropins, that is serum FHS concentration should be above 40 international units per liter. Then reduced circulating androgens and very low estradiol levels. And all these factors also contribute to your primary ovarian failure and early menopause. Induced menopause is permanent cessation of menses due to removal of the ovaries because of either surgically or ovary ablation by chemotherapy or radiation because of any other treatment. So it is characterized by abrupt loss of ovarian function. So the circulating estrogen levels and progesterone levels drop within 24 hours. So, and whereas FSH and LH levels surge. So abrupt onset of symptoms like all the unwanted, annoying symptoms like hot flushes, vulvovaginal atrophy, mood changes, sleep disturbances, headaches, joint pain, dyspareunia, and sexual problems, all of them come in at a once, attacking the lady who has undergone this induced menopause. So in this picture you can see the because of the desynchronized secretion of your gonadotropins, there is going to be the stoppage of ovarian function, which will lead to the loss of menstrual cycle, which will lead to urogenital atrophy, vasomotor symptoms, mood and sleep changes, cardiovascular diseases, and osteoporosis. So we will have a view of all these complications and how menstrual hormonal therapy is going to help, and in what modality it has to be given for each circumstance situations. It's not generalized. Actually, each situation needs a circumstance. Tailored or customized treatment by your hormonal therapy. So before starting any hormonal therapy, so it is very much necessary to take all these things into your consideration. So each lady is examination should be done according to the results. We have to plan the hormonal therapy. That is your history taking, physical examination, the liver function, kidney function, and full test for anemia, fasting blood sugar, and serum lipid profile, followed by mammography and bone mineral density test. That is your DEXA scan and the pap smear screening. Everything should be done for all. This is general examinations. And some elective examinations required to be conducted prior to MHT, that is thyroid function test, breast ultrasonography, endometrial biopsy. And so these are individualized tests, and according to individualized risk factors, we have to plan the treatment. And these basic examinations and elective examinations are to be conducted at an interval of 1 to 2 years, even after starting your menstrual hormonal therapy. Feminine hormone estrogen is going to be lost after menopause. So the mandatory has to be replaced. So how it is replaced? There are 2 modalities. That is, one is oral estrogen. Any estrogen can be, results in activated protein C resistance. See, the oral estrogen, when they go into the circulation, they go to the liver, metabolized, and in the small intestine also it is metabolized, and only 10% reaches the target organ. So the very high dose has to be given at a starting dose of estrogen. So it leads to lots of complication, but the target receives only 10% of the administered estrogen. And also, because it is metabolized in the liver, it meddles with the coagulation factors there and it increases the activated protein C resistance. So the tendency to form clots and thromboembolic phenomenon becomes very high with estrogen. So this is the negative thing of oral estrogen. So, but this can be overcome by administering in different forms. That is transdermal estrogen. Because it is transdermal, it bypasses the liver, so that risk of blood clot formation can be negated. Progestogens. So since madam has told you sea full of ocean full of names, just I will highlight the thing. What is a progestogen? Term used not only for progesterone but also progesterone like substance known as progestins. So the choosing the progestin is very important to combine the progesterone with estrogen, because only estrogen acts on the uterine endometrium, it causes endometrial hyperplasia and it leads to endometrial cancer. So the progesterone should be combined with the estrogen. So the progestin should be chosen very carefully because it has its own side effects. So progesterone is different as progestin is different. It's a synthetic component, and progesterone is a natural and bioidentical hormone which can be more beneficial than the progestin. And also there is oral form of progestin which also can be used vaginally, but it has not got its FDA approval. So adding a progestin, it carries very important point. So because women who cannot tolerate oral progestins, so whether they are given cyclic or continuous regimen, the oral progestin, if they are not tolerating, means we can use levonorgestrel releasing intrauterine device. So these are some of the progestogens. So appropriate progestin has to be selected and used, and clinical selection of progestins for HRT is critical in determining the potential positive or detrimental effects. So the drug which madam mentioned in the previous topic, drospirenone, is a new progestogen which has no androgenic and adverse lipid effects, and also it has anti-aldosterone effect which prevents the bloating, which is a very common side effect of your hormonal therapy. You can see here the drospirenone, it has the anti-aldosterone effect. So how is HRT given? It is given as monotherapy, as a cyclic estrogen, or continuous estrogen, or continuous progestogen, or in a combination therapy, that is, it is sequentially combined with treatment-free intervals, sequentially combined without treatment-free intervals continuously, or sequentially combined without treatment-free interval and different estrogen dosages. Or it can be also continuously combined. The tricyclic, four-phasic, everything madam has told, so I am not going to the drug details. So what are the prescription of routes? Transdermal, subcutaneous, intramuscular, oral, intrauterine, intravaginal, tablets, ring or cream. So these are all the vaginal creams and rings which locally give the estrogen. These are the transdermal patches. And these are the conjugated estrogen vaginal cream. There is a debate going on to use a bioidentical hormones. For example, phytoestrogens, they tell they have a bioidentical, the structure is same as your estrogen, but it is the bioidentical hormones are better than the synthetic hormones. The debate is going on, so but it has not been concluded, so we will talk about later. First, we will come to the menopausal transition. So about 40 women who are going to face the perimenopause or the menopausal transition. So the treatment only does not target the hormone replacement therapy. So all the other lifestyle modifications also very much help. So the treatment is 50%, the lifestyle modification should be 50%, such as weight loss, stress reduction, hypnosis, cognitive behavioral therapy, and all the supplements like omega-3, vitamin E, ashwagandha, isoflavin, that is the from the soya beans, and S-equal, a metabolite of soy isoflavin, seems to be highly effective than the placebo. So in menopausal transition, it's a period from the moment of increased variation in the menstrual cycle until the moment of immediately prior to the last day of menstruation. It varies among individuals, and often includes the vasomotor symptoms like hot flushes, which appear from 1 year to 3 years prior to the last day of menstruation. So the annoying starts before 3 years of your menopause only. And frequent and excessive menopause, that is the irregular periods, low self-esteem, sleep disorder, and feeling of decreased energy. So what type of menstrual hormonal therapy will be targeted for the menopausal transition? So combination therapy of levonorgestrel releasing intrauterine system with oral or percutaneous estrogen is very effective for controlling the hot flush or also preventing the endometrial hyperplasia. That is like only estrogen, if it is given, it induces the endometrial hyperplasia. So you combine with the progestogen, so it suppresses the proliferation of endometrium. And also it improves symptoms that appear during menopausal transition like depression and reduced quality of sleep and increased anxiety. And low dose combined oral contraceptives, that is the lady will be still in her fertile period, so there is a risk of pregnancy. So the low dose of combined oral contraceptives will be very effective in controlling the acting as a contraceptive also, and also a treatment for the menopausal transition, and also it alleviates the symptoms of hot flush. So symptoms of during this oral contraceptive period, there is a period of 7-day free period. So, but that is okay if you don't have any symptoms. But if the lady is already suffering from hot flushes and she's affected by mood swings and night sweats, everything. So this period is also should be taken into consideration, and continuous combined oral contraceptives like Clara, that is I think it is a brand name. So with a shorter free period should be considered. And also your smoking, obesity, hypertension, CVD should be ruled out. It is for mandatory for all the types of your hormonal therapy. And alternative therapies like diet and black koshosh, I don't know what it is, stick with some herb. And also the supplements, calcium, magnesium, vitamins D and E should be considered. So the recommended RDA should be given properly to the lady. So this will be the planning for the menopausal transition. So now coming to the symptoms of menopausal transition and also the menopausal symptoms. 3 symptoms are very annoying, and your genitourinary atrophy and the symptoms and signs related to the genitourinary atrophy, and the prevention of the most dreaded complication is the osteoporosis. So the treatment of these 2 symptoms and prevention of osteoporosis to be taken in consideration while planning an hormonal therapy. So if you see there are menopause, estrogen fluctuation is there. So the abnormal thermoregulatory system. So what happens? You don't have a normal thermoregulatory system, so hot flushes happen. So what are hot flushes? There will be a feeling of heat in the face and neck, and which spreads throughout the body 4 to 6 minutes, and it can be frequent also, and in the night it is more of night sweats. Okay, then there will be sleep disturbances, insomnia, and because of the night sweats also there will be a disturbed sleep pattern, and the mood swings, irritability, sadness, tension. It is both by the menopausal hormonal depletion on the brain, also it is due to the symptoms which she is facing. And cognitive deficits are very well known, so the brain fog, brain fatigue, so we don't remember why we opened the fridge, and again we go to the kitchen and come back again, then we remember we came to take then again we came. I think most of us would have experienced at my age group. And work related difficulties also will be there. The quality of your work, productivity is reduced, and also the quality of life. We are embarrassed, anxiety and fatigue, everything is happening with this. So menopause, so it is, you feel like that, you go and sit in the fridge to feel cool, or your best friend is the fan. So doctors in countries who they live in a very cool country, this hot flushes may be really annoying and they'll be depressing for them. So they complain more of hot flushes and it has to be treated for them. So they take the hormone replacement therapy very serious. So they advise layered clothing. So called loose fitting clothing, layered 1 or 2, 3 layers of cotton clothing, and they recommend a hand fan, which is always you will have a hand fan and cool yourself. And exercise is very much beneficial in helping in hot flushes. So if you see, so it can be treated by placebo also. So if you see the statistics, a placebo showed 20 to 40% reduction of symptoms, and a very extreme low dose therapy, it showed 55% reduction in symptoms. So low dose therapy showed 60 to 70%, and the standard dose therapy showed 80 to 90%. I think if you want extremely low dose and adopt all other lifestyle modifications to encounter the hot flushes. And also the other drugs, gabapentin and SSRIs are also very much effective in treating the hot flushes. So the highly effective minimal dose was to be progestogen, that is medroxyprogesterone acetate, 10 milligram per day plus oral megestrol acetate, 20 milligram per day, and MP 300 milligram per day. This is said to be highly effective minimal dose. So the point of our menopausal hormonal therapy is to give the lowest possible dose to avoid the complications. And the next dreaded complications, or which is very annoying and very painful complications, is the genitourinary syndrome of menopause. So just because protective effects are gone, and so the lack of lubrication, burning micturition, itching of the vaginal canal, discomfort with the intercourse because of there is lack of lubrication, and genital dryness, vaginal burning, urinary incontinence, urinary urgency, increased frequent urination, everything happens in this genitourinary symptom of menopause. Once a patient told me, "Ma'am, I hate that area itself nowadays." That is the exact word she told. So, so this much amount of discomfort it is going to give to the patient, because there is going to be vaginal atrophy and thinning of the epithelium, and there is going to be dryness, and atrophic vaginitis can by itself friction can cause abnormal vaginal bleeding, which in postmenopausal period, which is very frightful, they think otherwise. Postmenopausal bleeding means they think otherwise, and the sexual life is also going to be affected. So the marital problem also happened because of this. So these are all the local creams, and the well-known cream Primarin, that is estrogen cream. So it is very effective in treating this genitourinary symptoms, even though this is the most, but it's the easiest way to, it has the easiest way to treat, that is the local creams and gels of estrogen. But when you give the treatment, estrogen therapy for 1 year, it was associated with complications like vulvovaginal mycosis, vaginal bleeding, endometrial hyperplasia. Even though it is a localized preparation, absorption may be there. So it can also lead to endometrial hyperplasia, and it can lead to endometrial cancer. So this also be taken into consideration. Vulvovaginal mycosis, you need not be very scared, and it can be treated with our local antifungal creams and all. Latest is our carbon dioxide laser therapy has been shown to improve the sexual functions and alleviate symptoms like dyspareunia, itchiness, burning sensation, and dryness. And one journal advocated that continuing the sexual activity itself is a protective this thing to avoid all this things, even though with the help of lubrication gels and localized use of your estrogen cream. So if the sexual activity is continued means, so the complications become less and less because of the continued sexual activity. And localized DHEA and osmifene can be effective in treating this genitourinary system of syndrome of menopause. So the latest drug, tibolone, I'll come to after that, but just this is a clinical evidence, the long-term effects of tibolone on urogenital systems, which is little bit having lesser complications than the usual standard menopausal hormonal therapy. So this drug is the latest drug which is now extensively used in treatment of the genitourinary symptoms of menopause. And the next dreaded complication, or that is women are special, protected by the estrogen and protected because of their cardioprotective activity. So they have the less chance of facing the cardiovascular accidents. But after menopause, because of the depletion of the estrogen and progesterone hormones, we become equally vulnerable to heart attacks and coronary heart diseases and all. So summative risk for the relative risk for coronary heart disease for 40 to 50% lower among the current or previous uses of hormonal therapy. So it prevents against the coronary artery disease. HERS and WHA, this two words, extensive, a huge study conducted on the menopausal women, which I'll elaborate soon. Just I will tell afterwards. So taking combined HRT for 10 years immediately after the menopause has reduced the risk of heart disease. So this is what I want to highlight. So when you start the menopausal therapy is very, very important. That is immediately after menopause, within 1 year, if you start the hormonal therapy, and you have a lower risk of coronary artery diseases. But age is above 60 or the lady has past 10 years without hormonal therapy and the treatment is started after 10 years of menopause, the risk increases actually, contrary to this reduction. It increases, the cardiovascular risk increases, and they are prone more to cerebrovascular diseases, cardiovascular diseases. So this unpins the idea of window of chance. Window of chance means when the HRT is started, how long it is prolonged, and when it is stopped. That is very, very important, the age at which it is started. Okay. So you can see in this graph, so from 50 to 59, 60 to 69 and 70 to 79. So the risk is going on increasing, age increases even with the MHT. So within a proper age, that is in the perimenopausal period, or if it is started immediately after the menopause or within a year of menopause, the benefits are very high with menopausal hormonal therapy. But after 10 years, or above 60 years, even if you are starting the menopausal hormonal therapy, it is going to give the opposite effects where your cardiovascular accidents are going to increase. And just because of our also less, and they are responsible for libido and sexual function, androgens treatment were also considered. But they are also testosterone likely to influence the breast, brain, and cardiovascular and musculoskeletal system. So it should be considered with a pinch of salt. So it should not be, and the effects are also not very well studied. So a little bit a small interesting story about this menopausal hormonal therapy. So till that, the menopause was considered as a disease actually. So it was cured by purely the male physicians. Of course, there were only male doctors during that time. And the people who, the ladies who come to them, they were considered as they are having some disease, and so they used some abnormal treatments like cupping, and they put them in ice cold water and all, and also they did a downright mutilation, that is the clitoris was removed, and so all these demonic treatments were done on the ladies for menopause. Then they, at the early 20th century, the estrogen was discovered, and it was given in the form of conjugated equine estrogen, which was got from the pregnant mare's horses. So when this estrogen was given, so there was a dramatic decrease in the vulvovaginal atrophy and the hot flushes. So the ladies were very happy, and the pharmacist companies, they were booming, producing all this estrogen derivatives, and they were targeting the women, and the men was also targeted. How they targeted? The headache. She will not be, she will be, the beauty will be regained again. So men are only targeting in that part of the female, so they also were targeted, and so the industry boomed like anything. But when they found out only estrogen caused endometrial cancer, then the progesterone was. And after some time, they found out that there was a increased risk of breast cancer. So there was a huge study which was called as Women Health Initiative, which it was a double-blinded and RCT study, which gave the results of this treatment based on the menopausal hormonal therapy. But it was misinterpreted. Before the researchers gave their proper explanation, the news was spread out all the world that menopausal hormonal therapy was causing breast cancer and cardiovascular risk. So again, the sales went down, and again the researchers have to explain them, and they formulated, and then only the window of chance was formulated. So the researchers told that the period and when the heart therapy should be started, everything determined the complications and everything, and then only slowly again the menopausal hormonal therapy was started again as a treatment for the menopausal symptoms. So the trials, the huge trials, were named as Women's Health Initiative in 1990 and Observational Questionnaire Study in UK, and the Heart and Estrogen Progesterone Replacement called HERS in 1990, and the Women's Estrogen for Stroke. These are all the tests which conducted. So coming to the prevention of osteoporosis, so we know estrogen has a beneficial effect over our architecture of the bone, and it has the trabecular bone has to be the remodeling between your osteoclast and osteoblastic activity was controlled by your estrogen therapy, and the bone health was maintained by estrogen. Withdrawal of estrogen naturally resulted in osteoporosis. But the response when we give estrogen as a therapy, the response of bone density to estrogen was dose dependent. That is, it depended upon the dose. So reduced efficacy in low and ultra dose was seen. So we cannot adopt that same principle that we should take only the lowest dose possible, safest dose possible, because osteoporosis was not responding to the low and ultra dose of therapy. So now the prevention, the first line of drug for prevention of osteoporosis is not estrogen. So they don't advise estrogen as a primary first line of preventive treatment for osteoporosis. The other treatments are given, that is along with the other mode of tablets are not hormonal, and which acts upon the other sides of this thing. I'll tell what are they. And the if there is a established osteoporosis, bisphonates are used along with your calcium and magnesium and the vitamin D supplements. But in one case, that is your premature ovarian insufficiency, POI, you have to give the menstrual therapy for the because it is very rampant and very sudden, also sudden loss of mineralization is there, so demineralization will be there. So to prevent that, you have to give menstrual hormonal therapy in primary ovarian failure. Here also the drug Tibolin is very effective if it is prescribed early. And another this thing is loss of your muscle, that is called as sarcopenia. So the intramuscular fat, the muscle mass goes down, the muscle strength goes down, and your increase in motor units, type 2 fibers, there is decreased calcium release. So there is sarcopenia, which is the muscle mass is decreased. So that also leads to the weakness of the lady. So and there is a condition called as gluten tendinopathy. So that is also because the lady will be complaining of hip pain. You would have seen in your home, your mothers and all will always be complaining of hip pain side of the hip. So they were thinking of weight gain, everything and all. Now they say it is called as a menopausal condition called as gluten tendinopathy, and it is due to because of the estrogen depletion. And the menopause brain. So the inability to think clearly is not all in the mind. Is it depression or it is dementia? So the positive effect of estrogen on your hippocampal cells, you can see there are two types of receptors, estrogen alpha and estrogen beta. So there is one classical pathway, non-classical pathway. So the estrogen combines and gives its effect in the genomic and non very important for your cognition, concentration, everything. So this effect is lost in the menopause. And menopause is a pro-inflammatory phase. So whenever there is lack of 17B estradiol in the circulation, so you can see all your inflammatory biomarkers are increased. So there is an inflammatory situation in the whole body and especially in the brain. So which leads to all the cognition defects, your mood disturbances, sleep disturbances, everything. So and also the autoimmune diseases also slowly come up during this time because it is a pro-inflammatory phase. The inflammation increases in the perimenopausal and menopausal stage. So how does estrogen therapy helps in cognition? So again here the condition comes, the early menopause you treat, the estrogen is supplied, it is neuroprotective and all the positive effects, that is the increased acetylcholine activity and the serotonin system, everything is positively stimulated and you have a neuroprotective effect. There is a less chance of developing dementia and thereby the Alzheimer's disease. But if it is given in the later 10 years, it becomes neurotoxic and the cognitive disturbances and it can lead to Alzheimer's also. And the breast cancer. Always, madam said before this topic, you have to ask the patient whether they are having breast cancer. So, not only the patient is having breast cancer, also if there is a history of breast cancer in the first degree relatives, they should be first inquired and then only the hormonal therapy should be given. Because the progesterone which give along with the estrogen, they act on the breast tissue and they downregulate the estrogen B receptors which suppress the proliferation of breast tissue and they cause breast cancer risk. So there is always the risk of breast cancer. So always we should inquire about the patient had breast cancer or the first degree relatives, a mother or grandmother or they had breast cancer or something before starting the menstrual hormonal therapy. So long-term estrogen, only estrogen if you are giving, you will have endometrial hyperplasia and we have to add a progesterone to curb the endometrial hyperplasia and to prevent the endometrial cancer. But again, if you are giving this MST in above 10 years of menopause, again the risk of endometrial cancer increases. So the timing is very, very important. And the latest research about the gut biome. So this is now told to be the reason for all of the diseases, whatever possible diseases you have in your body, our gut biome, the gut-brain axis. So if you can see here first, in the normal period, center it is the normal reproductive phase where you have a good amount of estradiol and estriol. So you can see the gut biome is very healthy and there is lots of lactobacillus even in the vagina also. So the vaginal pH is also maintained, the vaginal biome is also maintained and the gut biome is also maintained. But after menopause, when there is no estrogen, all the leaky gut, that is the tight junctions in your intestinal epithelium wears off and all the pathogens and foreign bodies enter into your body and all the autoimmune reactions and it goes straightly through the vagus nerve to the brain, and the gut-brain axis is damaged, and so all other diseases are ensues. So now the treatment is gut biome should be maintained with lots of probiotic diets and avoiding junk food, everything. So if you maintain a healthy diet, so the gut biomes are going to help your both gut and vaginal pH also. And this is the thing what I was talking about, window of opportunity. So when do you start for the primary ovarian failure? Immediately after the girl has undergone a surgery or this thing, immediately it should be started. Or if it is early menopause for 45 years, the menopause has ensued. If the symptoms are very severe, menopausal hormone therapy should be started, and it can prolong up to 10 years. Even after 10 years, it is very risky if you're this thing. So this window of chance or window of opportunity should be used. The lowest possible dose, it should be used. Lowest possible dose, which gives maximum benefit. So these two things are to be kept in mind when you're starting a hormone therapy. So this is the algorithm. How you start with your. So if a lady is having a uterus, intact uterus. So if she is having a intact uterus, means definite estrogen is going to give a endometrial hyperplasia. So the progesterone should be added. And if there is no uterus, only estrogen is enough. So she can the treatment can be treated according to that. And if there is no endometriosis, the treatment can be started according to that. That is estrogen alone, and HRT, oral patch or implant, whatever it is, we can decide according to whether you're going to give a oral menstrual therapy or hormonal therapy, or your the localized patterns of therapies. So what are the steps? You assess whether the patient is right for menstrual therapy and the therapy options. Starting, how do you start, at which period you start, you have to decide that. Follow, do the investigations, individualized investigations like mammography and the vaginal cytology and all the other basic tests 1 to 2 years regularly. And when you have to stop, it should be stopped. Stopped abruptly, and it should be tapered, and properly it should be monitored and stopped. So what are the contraindications? It is specified by your regulatory authorities, that is suspected or current or past breast cancer, or any estrogen dependent malignant tumors, or undiagnosed genital bleeding, untreated endometrial hyperplasia. If there is a history of venous thromboembolism, because estrogen passes through the liver and meddles with your clot mechanism, so there is a risk of. So you have to take it into mind in that. And any untreated hypertension, because hypertension again is a complication of your menstrual hormonal therapy. Even though it is cardioprotective, hypertension is a complication of menstrual hormone therapy. And active liver disease, because it is going to be metabolized in liver, so a liver function test to be done, and then only it has to be started. And then as usual, any hypersensitive to the active substances, or any porphyria cutanea tarda, that is an absolute contraindication. So what are the main risk factors? Older age, above 60, no. Obesity, no. If there is insulin resistance, because estrogen again is going to meddle with your metabolism, so that insulin resistance means, so definitely she is going to end up in diabetes, type 2 diabetes mellitus, and its complications, and dyslipidemia, and your hypertension, smoking, everything should be main risk factors for your hormonal therapy, and it should be advised. So counseling is very, very important with the patient. She should be informed about the complications. She should be counseled to stop all her bad habits like smoking, sedentary lifestyle, everything. And also the personal family history of venous thromboembolism should be taken for her father or anybody is having venous thromboembolism. So these are all the risk factors. But if the symptoms are very annoying or very serious because of menopause, all these risk factors does not stop the doctor to not to start a menstrual hormonal therapy. So the treatment should be tailored according to each patient with very high caution. The same thing. So just to the recent drugs, with this I will finish. There's tibolone. It's a 19 not testosterone derivative as well as a combined steroid, and has the characteristics of androgen, progesterone, and estrogen metabolite. So it a special thing is it acts as a similar role as estrogen via the estrogen receptor. So it will alleviate all your annoying menopausal symptoms, and also it is very much useful in prevents the bone loss of the menopause while not irritating the breast and endometrial this thing, which is very much needed. It is almost like an ideal drug, I think. Experts from OG should tell me. Like, it does not irritate the breast and endometrial this thing. It shows in selective tissue selectivity. That is the basic mechanism of action of this drug, tibolone. So it is almost used in all symptoms like your hot flush, your genitourinary symptoms. It has low incidence of vaginal bleeding. It effectively treats the sexual dysfunction, and also it helps in mood disorders, sleep disorders, concentration disorder. It increases the bone density. It reduces vertebral fractures and does not increase the invasive breast cancer and endometrial. But it should be used with caution with already the patient is having breast cancer or endometrial cancer, and also it does not affect the venous thromboembolism. So I think it should be a very good drug, but you should always have a caution when starting with above 60 years. So this is tissue selective estrogen complex. So the drugs select the area like where you want to exert your positive effects. It's called as tissue selective estrogen complex treatment. So this two drugs, that is your combined estrogen and BCA, I don't remember the name. So these two drugs, it is very safe, and it increases the bone density of the lumbar spine and hip joint, and also it has a very low incidence of vaginal bleeding, breast pain, and increased breast density. So this drug, this treatment can be adopted in the latest treatment. And the extra treatments, essential oils, evening primrose, lavender oils, they can be used to uplift the mood. This again the selective estrogen receptor modulators. So these drugs are now latestly used, and these are the emergent opportunities, the new research which is going on in the menstrual hormonal therapy. One is cell-based hormone delivery. So this concept is of designing an artificial ovary. So what they do is they dissect all the cells in the ovary, and subsequently they amalgamate the cells. They separate the theca cells and granulosa cells, and they make it in a 3D micro tissue, and they inject into this, and it's like an artificial ovary. So it was very nice to study. Maybe it is under the research process. Maybe in due course after 10 years, our own ovary again back into the menopausal woman, so which can she can regain her functional ovary. The topic, boon or bane. So the balance of benefit to harm always needed to be assessed, and it appears to shift favorably for HRT. So as I said, if the women start HRT at menopause, the risk is very small, but after 60 years, the risk is high. So it isn't typically suitable for women of more than 60 years to begin with HRT. It has to be decided according to the complications. Used sparingly in the specified patient population. Duration should be kept in the mind. So hormone replacement therapy could be very well proved rather than the bane. Thank you for your patient listening.
Thank you, ma'am, for such a clear and extensive explanation of what menopause is and how we are going to choose the treatment for hormone replacement. Thank you so much. Any
Thank you,
questions?
ma'am. Thank you, ma'am, for that presentation. Now the session is open for discussion.
Miles of injectable testosterone used to be given, isn't it? Is it still being given? Not being. 0.1 milligrams used to be given as injectables. The gynecologist said that it uplifts the mood.
That is because of the recent drugs given and all, it has its androgenic effect also, ma'am. So that the proper testosterone, I think it's not given. It is replaced by tibolone and prospirone and all.
Thank you, ma'am.
Thank you for the wonderful presentation. I have learned a lot today from, like any other drug in the universe. The side effect of tibolone is it is associated with breast tenderness, vaginal bleeding over long term, and is known to cause thrombosis. So I think the take-home message of ma'am's presentation should be lowest dose if indicated. And the cost of tibolone tablet per tablet is 50 rupees. Per month it is 1,500 rupees. So how many of our patients would be able to afford it? Now, that is also to be taken into account. I think best treatment against osteoporosis is exercise. If you are able to maintain a healthy lifestyle in your 40s and carry it through to the 50s, you really any of the extra supplements except calcium to maintain bone strength. For urogenital system, vaginal creams are still being used. How they use it is there are few months overwhelming. So at the time, 2 to 3 days a week, Pramarin cream use பண்ணுவாங்க. But after those 3 months, they stop it. So periodically, but nevertheless, just because it is like friction to be used only, you cannot live with it, you cannot live without Marina. So do not use it unless really indicated. Nothing is too safe. Thank you, ma'am. After which it starts reducing. So on the time it is Pramarin vaginal creams you can take oral estrogen tablets because even that hot flushes is usually during the first year only. So on the time we can consider estrogen. Like madam said, in the immediate post-menopausal state, I think that will be the most effective.
1 to 3 years?
Yes. Yes. And OCPs are not usually used. Why? Because OCPs have ethynyl estradiol, which is a very, very potent estrogen. I would say, because the potency of the estrogen is less other symptoms. And usually the patient where the ovary is there, you combine progesterone and estrogen. Whereas in the absence of ovary, I think estrogen alone is. The patient where the ovary is there, you combine progesterone and estrogen. Whereas in the absence of ovary, I think estrogen alone is enough.
I think again there are specific exercises for the.
Yes, ma'am. The Kegel solluvom, but how effective it is, it's not a one-day thingy. It takes a long period of time. They say there is effect in yoga. I think it is basically of the priming of the brain, as a result of which we feel better.
Thank you.
Thank you, ma'am. Pendulum flax எல்லாமே யூஸ் பண்ணிருக்கலாம் sir. How long are we going to use it for is the yes. Yes, SSRIs, SSRIs are being used more for hot flushes. The most effective for the urogenital symptoms. Yes, there are we prefer not to go for estrogen if it is just simple hot flushes. The thing is, you try to stop as aging.
Even when I wanted to do some research on pulmonary function tests and menopause, okay, one pulmonologist said that this happens during aging. Why do you want to study it in menopause?
Need to give the women emotional support because the body is undergoing a lot of change. And I think that emotional support, family support goes a long way in alleviating many of the symptoms of what I just
Ma'am, I think especially the
especially. Question.
Bioidentical hormone is available for treatment, and whether it is better than, you said it is better than synthetic.
Yes, ma'am. There is an ongoing debate about this progesterone, which is like identical to the our natural progesterone structure is synthesized and made in the lab and given the patient means I read in one. So they offer a very good effect instead of progestins and progestogens. Progesterone, the bioidentical hormone, they have a good effect other than the synthetic this thing. But the research is going on whether you can produce a exact bioidentical hormone, progesterone. So they suppressing the breast tissue which is being acted upon by estrogen. It doesn't proliferate the breast tissues and it can suppress the development of breast cancer.
So I like to congratulate Niraimadi for an excellent presentation. I'm very proud that physiologist doing a good thing. First time I'm listening to Nirai as giving a talk. So she must be a very good teacher for me. So when I saw the topic, hormone replacement therapy by physiologist, I was
Thank Dr. Mugil for giving me this excellent opportunity. With so many practical difficulties, I came to Trichy, but it was worth it to seeing all the old friends and the results of physiology and stalwarts of physiology, and also, ma'am, I'm very happy to be here. Thank you. Results of physiology and stalwarts of physiology, and also, ma'am, I'm very happy to be here. Thank you.
Thank you, ma'am. We invite Dr. Nachal Annalai, ma'am, to felicitate Dr. D. Naraimadi, ma'am, with the shawl and memento. Ma'am, with the gift. Thank you, ma'am. We invite Dr. Divya Seduraman, ma'am, to felicitate Dr. Nachal Annamalai, ma'am, with the gift. Ma'am, with the gift. Annamalai, ma'am, with the gift. Thank you, ma'am. We now invite Dr. Gautam sir to felicitate Dr. K. Uma Maheshwari, ma'am, with a gift. Thank you, sir. Thank you, sir. As we embark on this enlightening journey, let us engage in thoughtfulness discussions, exchange ideas, and learn from the field that brings form. Together, we aim to enhance arranged outside of the auditorium. After lunch, we will resume on prize distribution at 2:45.
I was surprised you were here. I was still thinking you were a gym.
யார் கேமரா அழகா இருக்கு When they were offered contraceptives, they agreed.
Contraceptive which can be used, or any estrogen. So this period